Good evening, delegates, and good evening, all the participants who have joined for this webinar on Shield Connect platform. Today, Foxy IAEC committee presents a webinar on acute complications in pregnancy. And today's our team is with Central Zone India MP. So before we start with the session, let me introduce our MOCs for the day, Dr. Dolly Mehra and Dr. Jyoti Banglowala. So, Dr. Dolly Mehra, ma'am, is past president of Ratlam Obstetric and Gynecology Society. Ma'am is organizing chairperson of AMPOGS, and Dr. Jyoti Banglowala, ma'am, is vice president of Indore Society and practicing gynec since 25 years. So, I hand over the session to Dr. Dolly Mehra, and ma'am, it's all over to you, ma'am. Thank you.
Good evening, everybody, and warm welcome to this important webinar on acute complications of pregnancy, organized by the International Academic Exchange Committee of Foxy. This is a very important topic, and we face it every day and day in and out. In this panic situation, it is very important that we are well versed with the protocols so that management of the patient becomes easy. On behalf of the International Academic Exchange Committee, I am grateful to our President Foxy, Dr. Shanta Kumari Ma'am, Foxy General Secretary, Dr. Madhuri Patel, all our Vice Presidents of Foxy, particularly Dr. Kavita Bapat Ma'am, for giving us this opportunity to organize this webinar. Immense hard work has been put in to organize this webinar by the IAEC committee chairperson, Dr. Varsha Baste Madam, coordinators, Dr. Pratibha Singh, who is national coordinator of IAEC committee, and Dr. Shashibala Bhosle, president of Gwalior OBGYN Society. I request Dr. Varsha Baste to please say a few words and welcome our guest and guest of honor.
Yeah, good evening all, and a warm welcome and hearty welcome to all of you gathered here. The August gathering, I can see the heart of MP, the heart of India. MP is there, and there's so many stalwarts are there, Gwalior and Indore and all the Sagar, all societies, many societies have gathered to witness this academia. And I am really thankful for everybody for joining in such a large number, and many are still joining. We are awaiting their presence. Foxy International Academic Exchange Committee started these webinars for the sake of general practicing gynecologists and general practicing Foxians. Everybody is doing specialization, and all the webinars are done for ART and for some specific syndrome and some niche marketing, something like that. But we thought we should have webinars only for the general practicing Foxians who are doing cases, who are examining cases in their OPD. So acute complication in pregnancy, it was one of them. We started with normal labor. We started with NCDs in pregnancy. So we wanted to update the general practicing Foxians. So this is one of the webinars where we are going to deal with acute emergencies, complications of pregnancy. And we have our chief guest, Dr. Leela Joshi Madam. Madam, you are so hearty and warm and so loving and kind, always laughing and talking softly, so vivacious. She is senior gynecologist and MD FICOG Padma Shri awardee. We are really thankful for your presence, madam, and we are feeling delighted with only your presence. She is retired Chief Medical Director of Indian Railway, also known as Mother Teresa of the region. Senior Consultant Gynecologist at Ratlam, founder of Ratlam OBGYN Society, ROGS. Presently working to reduce maternal mortality in tribal and underprivileged by eradicating anemia. Besides Padma Shri 100 Women Achievers, there are many national and international honors awarded to her. So here, Dr. Leela Joshi, madam, I would like you to address the gathering and spread the pearls of wisdom with your knowledge, with your so much of high capabilities and so high credentials. And we are really delighted and honored by your presence. Over to you, Dr. Leela Joshi, Madam.
Thank you so much, Dr. Varsha, for kind words of introduction. Good evening to all my dear friends of Foxy. Today's guest of honor, Dr. Bindal, dear Dr. Rosa, and Dr. Vidya Pancholi. The organizing team of today's webinar, today's this scientific event, the chairperson of IAEC, Dr. Varsha, and the national coordinator, Dr. Singh, and dear dynamic president of GOX, Dr. Shashibala. She has reached here or not?
She is in traveling, madam.
She is in the way.
Flight was delayed.
She is in the way.
Little later.
She is in the way. And all our dear speakers, panelists, chairpersons, and these two MOCs, Master of Ceremonies, Dolly and Jyoti. My very best to all, each and everyone who are attending this webinar. When I first got this program, the thing which struck to me was that there are three full. Now, what are those three full? The first is the topic itself. It covers the full obstetrics. And second is the faculty, the cream, the full cream of Central India.
Yes.
And thirdly, the most important is the team, the enthusiastic team, full team. So these three, this struck to me the first impression which I had of this program, that there is a full obstetrics, there is a full cream of faculty, and full enthusiastic team. So what remains, I think, nothing remains. And not taking much time, little bit of the topic, the acute complication of pregnancy. Complications, as we know, are unpredictable, but we make it predictable by our knowledge, by our experiences. And with all these efforts, if complications do occur, we manage it, we remain mentally, physically, and resources-wise ready to tackle it so as we can minimize the damage to the patient. I would not take much time with these words. I would wish this scientific event a great success. But before stopping, I'll again congratulate you, Varsha, for starting this system of short CVs, because I personally feel it's very nice, really, because it takes away much of our time to, and we all know each other. There is really no need. I am very happy. I am very happy, and I wish that this system should continue of short CVs. Thank you so much. Thank you
so much.
Thank you, madam. Thank you. So, good evening, everyone. And now it's my great honor to welcome all of you today for this webinar. And my regards to Dr. Leela Joshi, ma'am. And now it's my proud privilege, and I'm really overwhelmed to welcome another star personality, Dr. Jyoti Bindal, madam. And I think for many of us, she is known as our teacher, our mentor. And I did my house job under her unit way back in 1989. So it's really nostalgic for me to welcome madam and introduce her. She is at present the Vice Chancellor of Sir Aurobindo University in Indore, and she has many achievements and many awards to her credit. She has held almost various posts in all over Madhya Pradesh, and at present she is Vice Chancellor in Sri Aurobindo University, Indore. So with this, I welcome Madam Dr. Jyoti Bindal, Madam, and I invite her to bless us with some pearls of wisdom. Over to Madam.
Thank you so much. Am I audible?
Yes, yes, Madam.
Because I'm in the car.
Yeah,
So thanks, Varsha, Pratibha. I think we should ask other people to mute. Too much noise. Mute, please. Yeah. I'm very thankful to Varsha and Pratibha and Palm for giving me this wonderful opportunity to be on the same platform as the icon of obstetric and gynecology, Madam Joshi. I think it's a proud privilege to share with her. Having said that, I think the webinar in itself is full of scientific pearls, real tackling the day-to-day problems, and it is the need of ours. We have wonderful faculty, wonderful topics, wonderful chairpersons, and I'm sure each one of you will do justice to the topic, and there will be a lot of interactive discussions. Thank you once again for having me with you all. Thank you so much. Over to you, Pratibha.
Thank you so much, Madam, for blessing us, and it's really very nice that you joined, and thank you so much. Now, it's my great opportunity, and I'm really excited to welcome another very well-known and my school buddy, Dr. Rosa Oliai. We were together in school and then in GRMC. So I'm so happy to introduce her. She was Vice President Foxy in 2014 and had a very successful chairperson Adolescent Committee Foxy in 2012. At present, she is Director Oliai Hospital and Research Center. And she again has a lot of awards and publication to her credit. With this, I request Dr. Rosa to say a few words. Over to Dr. Rosa.
Thank you, dear Pratibha. It's really nice to see you and doing so well from where to where you've come. And I'm sure you will come up in Foxy as a chairperson very soon. All the very best to you.
Thank you. Thank you.
But at the outset, I really want to thank and congratulate Varsha, Dr. Varsha Baste.
Thank you.
For, doing this over and over again in different states. I've been with her in different seminars and webinars. And Varsha, for the benefit of the audience who haven't seen you years back, when I was a Foxy Vice President in 2014, my Vice President conference was, you were Foxy West Zone at Nasik. You were the President of Nasik Obstetric Society. And you had done actually the first workshop, international workshop for Urogynec. And from then onwards, everybody has seen the way you're working. And, the committee you've taken up was once a committee where there was hardly any work to be done. I'm talking about days in 2014, 15, 16. You've come up with a wonderful work. And I'm so happy you're catering to the benefit of the common gynecologist with the obstetric, topics that you've joined in today. So wish you all the best. And of course, I must also tell the audience that she's got a beautiful aesthetic center in Maharashtra, in Nasik. So we should learn from her how she maintains herself. I'm so happy to share the stage with our very own, the Padma Shri awardee, Dr. Leela Joshi. We've heard so much about you, ma'am. And with all the guidance you've been giving me and pushing me to go in Foxy further on, up and up. Thank you so much to be present amongst, you, and of course, Dr. Bindal, who's been always a good guide to me throughout my career and my work in Foxy. She's been always helping me out to progress and encouraging me. And of course, none other person than my very own Vidya Pancholia. She's been the scientific chair to the ICOG. And I think you've done a wonderful work, Vidya. Good to see you here with me. And of course, the speakers that are here, I see a lot of friends. Dr. Archana Beser is the past Vice President of Foxy. She's done excellent work, and I'm sure she's going to work out more. And of course, other speakers whom I don't see many faces. Of course, my only friends who are here, Jyoti Karande from Bhopal, Jyoti Banglowala from Indore. Bridge, good to see you here. And from our Oni Society, Dr. Preeti Gupta, the Dynamic Secretary of Gwalior Obstetric Gynec Society, who's here. Good to see you. Palm, Dr. Palm is also here. I saw you in the airport traveling always weekends. And of course, other friends whom I'm not able to see right now, many of them. Dolly, of course, thank you for your introduction. Excellent work you're doing. I wish all the speakers, all the chairpersons, all the very best. And Varsha, we're always with you. Looking forward to see you climbing up the hierarchy in Foxy. All the very best. And of course, Madhya Pradesh, we need more people as chairpersons, as vice presidents. So please, all of you come up. We are always there to help you all. Help all of you. God bless you. Please go on, Pratibha.
Thank you for the kind words, Dr. Rosa Royaji. And I know you had come and you came, you saw and you conquered Nasik OBGY with your presence. And I can still remember the red flashy sari you were looking so rosy, and it was a really great oration given by you. Thank you so
much, Varsha. Thank you.
Thank you, Dr. Rosa. Now over to Dr. Shashibala Bhosle, madam.
Yeah, greetings from Goa. Sorry, I may not visible, Doctor, but Vidya Pancholi is very much here. And welcome, Dr. Vidya. And can I have a CV? Yeah, no introduction she needs. She is a senior obstetrician from Indore, and she's aesthetic masters in aesthetic gynecology and super specialty. So she was the pioneer in gynecological laser, I must say, in MP. So over to Vidya. I'd like you to say a few words.
Thank you, madam, and good evening to everyone. And it is a great opportunity and invitation to see all of you, the galaxy of superstars of Foxy, and looking to the subject which is really of a great clinical relevance to each and every gynecologist and practitioner. And of speakers, I must congratulate Dr. Varsha Baste, and that is indirectly showing your great leadership to move ahead this Foxy. And all the best and congratulations for your future endeavors, as well as whatever you have done for this society to move Foxy and the Foxian ahead. Thank you very much.
Thank you, Dr. Vidya, for your kind words. Thank you.
So to begin with the first session.
Yes.
We have a session on research in UK for medical students by Dr. Nachappa. The chairpersons for the session are Dr. Monica Singh, who is Vice President, Bhopal OBGY Association and Organizing Secretary of ISAR 2023. Dr. Neha Saraf, Secretary of Ratlam OBGY Association. Dr. Preeti Gupta, Secretary, Gwalior OBGY Association. I now request Dr. Monica Singh to please introduce our speaker.
Before that, let me just introduce, let me just acknowledge presence of Dr. Archana Basir, Madam, our VP, Foxy, and welcome Dr. Archana Basir. She is not at present there, but she was there, and I should have acknowledged her presence before only. But we welcome you, Dr. Archana Basir, Madam. Yeah, over to you. Sorry.
Monica, please introduce our speaker.
Yes. Good evening, everyone, and greetings from Bhopal. Thank you, Dr. Varsha, for including me in this massive webinar. And I'm delighted to introduce Dr. Nachappa Shivanesan. He is MS Orthopedics, MRCS. He's completed his MS in Orthopedics and Traumatology from the renowned Sri Ramachandran Institute of Health Sciences in 2015. He's well-versed surgeon in all surgical procedures, currently the advisor of Tamarai Fertility and Women's Care Center, Coimbatore. Welcome, Dr. Nachappa.
Dr. Nachappa, have you joined? Dr. Nachappa? Nishad, please ask the webmaster to contact Dr. Nachappa if he's there. Seiti,
Yes, ma'am.
I've contacted because he was supposed to join at 8:20.
Okay, ma'am.
Not there,
One
we
second.
take
Just
another talk. Otherwise, the next talk is okay. We will wait for him till then. I will just talk a few words. Dr. Asha Bakshi couldn't join because she had some urgent work. So instead of her, I will be giving the talk on my talk on ectopic pregnancy. Dr. Nachappa is there. He will deliver his lecture first, then I will deliver mine, or otherwise we will start with my lecture. And Dr. Kavita Bapat also couldn't join because she is busy in VP meetings and conference preparation, and she is traveling also, but she has sent her talk and video recording for display here. So I will be displaying that also after my talk and Dr. Nachappa's talk and Dr. Archana Base's talk. Is that okay, Dr. Dolly and all?
Yes, ma'am.
Okay. I will just check with Dr. Nachappa if he's there. Otherwise, we will start the webinar with my talk. Just a minute. Huh?
Hello.
Yeah, he's joining. He's trying to join. He's joining within a minute. So till then, I will just acknowledge the presence of all the stalwarts. I can see Dr. Brijabala, Dr. Mamta, Dr. Jyoti, Dr. P.K. Roy, sir, Dr. Uma Nigam, Dolly, and Dr. Monica, my friend, and Dr. Richa, and many, many more, Amita Saxena, Manisha Maheshwari, and many other stalwarts are here. And all of you gathered, and we are obliged on behalf of Foxy International Academic Exchange Committee, your presence and your involvement and your participation and your so much precious time you have given for us and for this academia. I am really obliged on behalf of International Academic Exchange Committee, my national coordinator, Dr. Pratibha Singh, and the national coordinator elect, Dr. Pam. They are working very hard, and each and every way we are organizing fortnightly webinars, and all zones of India are covered. And now we are next webinar will be in Maharashtra, because Maharashtra and Gujarat is very big, many societies are there. So we will be doing 2-3 webinars over there. And we are also going on research. So another set of webinars will be for students, medical students, the DGO people, the students, the lecturers who are interested in research and foreign education and education after PG, and many other non-clinical branches, how to get the admissions, how to know the people, how to know the universities, everything, and also about the international publications and all. We are going to have webinars in September. So do join and get updated about this part of this academic part also. But publication is also very important, research publications. So do join that also. Again, just a minute.
Madam, in the meantime, can Dr. Neha introduce the topic?
Yeah, please.
Yeah, Dr. Neha, chairperson, second chairperson, please introduce the topic, research in UK for medical students.
Thank you, ma'am. Good evening, everyone. First of all, I would congratulate the whole IAEC team for organizing this webinar, and thank you for making me a part of it. It's our pleasure to hear Dr. Nachapa on a one-of-a-kind topic, research in UK for medical students. Sir himself is from UK, so I'm sure we'll get useful tips from his talk on international fields. I welcome you, sir, and request you to start your talk.
He just talked to me and again got cut. I will just give him a call, and otherwise we will take it. We have to wait for 1 minute for him. He's trying to get linked, joining. Dr. Saiti, please help him join.
Yes, ma'am. Just now I contacted him. He's about to join.
He's facing some difficulty, I think. Please help him.
Okay, ma'am.
Sorry, audience, for this interruption, but I could have started my talk, but the time limit for UK is it's quite sensitive issue over there because they are bound with some time. He has just borrowed some time for our webinar, so we have to give him preference.
Varsha, meanwhile, you can update us about your upcoming conference.
Yeah. See, now what we have done is we have now there is a Turkey International Academic Exchange Committee has organized a conference in Turkey because we thought the update should be also taken over by international speakers also. So we have arranged a Turkey tour also. It will be at Antalya, Istanbul, Antalya, and all the Cappadocia, everywhere. And the speakers are President of Turkey OBGYN Society, Secretary of OBGYN Society of Turkey, and they will be delivering talks. And Dr. Shanta Kumari also is going to give us oration. And Dr. Bipin Pandit is our committee VP guide. So he also will be having his talk. And we are going to have panel discussion also. And what I thought is we should have the update on the knowledge which we do not have here, or maybe we are lacking so many patients or but that much of research also. So I have given the topic to the person, the president of Turkey, irritable bowel. Irritable bladder. So that is a very important topic nowadays. The menopausal and all ladies are facing as stationary incontinence and whatnot. So the overactive bladder syndrome He's going to talk for half hour. And I told him to give all the updates about what work he's doing, extensive work in that field. So he will be updating us all the work and data, what are his results and what types of surgeries he's doing and how to do the medical therapies also, that he's going to update us in that platform of National International Academic Exchange Committee conference at Antalya. It will be on 14th of October. Yeah. So then if you want, we will be giving the recording also for display, and for our audience, it will be put on the Foxy website also.
Thank you, Usha. I think your speaker.
Dr. Nachappa has joined.
Yeah. Okay. Oh, Nachappa, doctor, sir, welcome. And you can start your presentation, share the slides. Are you there, Dr. Nachappa? Yeah.
Ma'am, sir has joined.
Okay. Help him share his slide and all, please, because we should not waste time.
And from attendees, this thing.
Hello, Dr. Monica. I can see you as a chairperson. You are doing lots of work in research, and Aishre is all famous because of you and Randir giving all the talks and new updates in ART. So I thought you are the apt person to chair the session of research, international research for medical students abroad, that Dr. Nachappa is going to deliver the talk.
Yeah, that is very right, Varsha. I have been interested in presenting our work in international conferences, because unfortunately, the conferences which we have in India, whatever are related to infertility, I feel that they are more focused on theoretical talks. People don't talk about research. People don't talk about their cases.
Yes.
So I think our speaker has joined, and so we will continue this discussion later.
Yeah, okay. Dr. Nachappa, please share this your talk and start.
Yeah, I'm just going to share my screen. Start broadcast. Yes. Okay. Okay. Right. So let's just go to my
Dr.
screen.
Geeta Balsarkar will be taking over many topics in research. Dr. Geeta Balsarkar, Dr. Girija Wagh, and also one Dr. Nachappa also will be there for on 7th of September, only on research. The webinar will be only on research.
Okay, can everyone see my screen?
Yes, yes, we can see.
Okay, wonderful. Thank you. Right. Okay. So my name is Nachappa Nash Sivanesan Raj. Some of you might know me from the earlier session, but for others, I currently an registrar working here, and I've been very kindly invited by Dr. Baste to talk about medical research. We did a very basic introduction for the last session. I think this session, we will go into a little more detail, and we'll start with medical research in the UK for international students. Now, I think I'm quite qualified to talk about this because I was an international student. I'm still an international student. And then when I came to the UK, it was quite a big bridge for me to cross in terms of the systems and how to understand how research is done here and how to integrate and start doing research here. A little bit about me. Again, I do 3 different roles as part of my job plan. I do a clinical role in which I'm a specialist registrar in trauma and orthopedic surgery. I do a teaching role in which I am an MRCS tutor affiliated with Cardiff University. I'm also a mock examiner for medical students, final year medical students at the Bath Medical School in London. And I will also do an adjunct role as an educational fellow at the newly built Kenton Medway Medical School in Canterbury. In terms of research, I was a clinical coordinator for a Innovate UK funded project. Innovate UK is a company that funds new ideas and projects. I did this project at the University College of London Hospital for 2
Sorry to
years.
interrupt, Dr. Nachappa. Your mobile is also on, I think.
Oh, sorry. I don't think my mobile is on. I can switch it off.
Because the voice is echoing.
Dr. PK Roy, please, sir, please mute yourself. Dr. PK.
Okay, now you can continue.
Okay, so I did my research role was I was a clinical coordinator for an Innovate UK funded project. Innovate UK is a kind of angel investing company that funds new ideas and projects. So I did a project for them for 2 years, apart from working as a registrar there as well, at the University College of London Hospital. And that also was my 2 years of research fellowship there. Now, I'm someone who believes that any talk has to be done within 8 slides, and any idea can be conveyed within, I wouldn't say has to be done, can be conveyed within 8 slides. And hence I've kept my slides to a minimum, but I'm going to talk more on each. Now, for anything, we start with a why, how, why, what, and how. So why is it important for international students to think about research in the UK? Because you will be involved most probably in a multi-centric project if you're initially starting off being based in India and doing something with someone in the UK or some center in the UK. It will give you a global perspective about how data is handled, about how data is collected, and about the different protocols, the guidelines, clinical guidelines, research guidelines, and about the demographics as well. Again, as I said, you will also understand the research methodology, which is quite different in the United Kingdom. It is different in the United States of America. It is different in India. And of all the systems that I found that the American system is quite robust because they do a lot of research. They probably have the highest volume of research in terms of publications and fundings and patents coming out than any other country in the world. And the protocols for research. And talking about protocols, the United Kingdom has probably the most watertight protocol. It's very regulated, extremely regulated. And so when you regulate any kind of research, the quality of the research that you do and the quality of the data that you collect automatically goes up. The value of the data and the value of your interpretation or publication definitely goes up. Now, how do you go about it? So at a very basic level, you can start with collaborations. I understand that a lot of people are practicing clinicians in India, and you can start with collaborating with one of the UK units. So there are a lot of study groups in the UK there. So for example, there's a COVID surge group, which is basically COVID surgery. And that is that is an initiative by the National Institute of Health Research, which is the central body for any research in the UK. So the NIHR started the COVID surge group. And what they did was they expanded it and made it COVID global surge. So what that means is that gave an opportunity for people all over the world to contribute surgical data in terms of outcomes and how they did surgery during COVID to this collaborative group. And they had a central team collecting that data and processing it and publishing it. So that's probably a good example. Then you have the Falcon trial. Then you have there's so many other trials. The Fruity trial. The Falcon and Fruity are basically UK-based trials, but the COVID global search is an international collaboration. That would be a good place to start for anyone who's willing to collaborate in terms of research in the UK. Now, if you want to go one step further, you can choose individual units. Like, for example, you can choose a unit in Leeds. Let me give you an example. In obstetrics, you want to do high-risk pregnancy. You find out where there's a lot of work being done in high-risk pregnancy. You look at the funding going into the different units, and then you communicate with them and you let them know that you want to be a part of it, and they will assess your skill set as to how you can contribute in terms of data collection, in terms of writing a paper, in terms of statistics. So those are all the different components that go into research. So you can make yourself useful by demonstrating your competencies in any of these domains. And by doing that, you can be a part of it, and that will lead on to further collaboration. But that again is quite hard. It's really hard to get yourself integrated into a unit unless you know someone, but that can also be done. What's the purpose of doing all of this? You collaborate internationally, you're part of a trial, you're part of a study group. For a lot of people like me, there's always the excitement of research. I mean, if you're that kind of person who's a stickler for rules, regulations, and you want it to be in a certain way, and you like to look at evidence, you like to examine evidence, and you like to update yourself based on evidence, because whole of medicine is just very dynamic. And how is it dynamic? Because everything is evidence-based. So what you do today as constant practice will not be constant practice, for example, a month down the line, because someone has looked into it, someone has gathered data, someone has found evidence that there's a better way to do it and has proved it by evidence that doing it in a different way gives better results. So you have to change yourself. Otherwise, you become a huge tenace in the room and you become outdated. So in medicine, you're constantly learning, you're constantly reading, you're updating, and you're running a race. And you have to be reminded of that. So with these collaborations, you can start presenting in conferences. With big trials and studies, it's not necessary that you have to wait till the end point to present your results. You can present midterm results. You can present, during the course of study, if you come across an interesting outcome, that can always be presented in conferences. Of course, publications, writing up. Now, writing up is a more detailed way of doing it. It's more meticulous. It is more vetted. So you need to be very thorough with your data methodology. You need to have a design, a plan, and a discipline to do it. And the third most interesting thing, I think this is very interesting in a country like India, is to set up registries. So I think we encounter many diseases that are not very common in the Western world. And we have to create the system where we set up registries where data entry is very detailed. And these registries over a period of time will yield significant amount of data to come to probably groundbreaking conclusions about what we do and how we do things. How does this, so in your journey, you start collaborating, you start being attached to a group or a unit, then you start going to conferences, you start presenting those results. It doesn't have to be the principal investigator, the chief investigator who has to present the results. You can do it. I mean, as long as you have an understanding and you have that dynamic within the team. And then you start writing up about things, and then people start noticing it. You become someone who gains significant expertise in that area. And then you start attracting interest from similar groups. As I said, you become you gain that amount of expertise. And then it goes on to a stage of validation of your work. It's a learning on the go. It's a huge learning curve. And there's a mutual learning process where you meet people from different parts of the world who are doing similar work. And then you start learning from them. You start building a network that way. And probably, I've put this at the end of this 3x3 matrix graph, because that's probably the most hardest thing to do, is to get research grants. To write proposals for research grants is probably a very stressful experience, even for people who've been in research for 10 plus years. So that is probably the last thing you should be thinking of in terms of getting funding for research, because it's very tightly regulated. You have to have a reputation, you have to be attached to a unit, and you have to have produced significant amount of work before they consider you for any kind of a research grant. What are we currently working on? I do have family back in India. My mother's into OBGYN. She's Dr. Kannagi Uttaraj. And we are currently working on COVID-19 vaccinations in pregnant women. So we're working on a series. We're going to present our results in Sheffield in October. We're also working on a home-based protocol that we devised for COVID-19 patients, pregnant COVID-19 patients during the COVID-19 pandemic. This is what I'm doing in collaboration with my mother's expertise. This is something that I'm doing on my own interest, and I don't know how much of interest this will be for you. So this is genetic assays for a disease called hereditary sensory autonomic neuropathy type 4. Type of neuropathy that leads to pain insensitivity. It affects the pediatric population. Their mortality rates are quite high, probably 90% plus within 10 years. It's a part of the Charcot-Marie-Tooth disease family. So I'm very interested in it. I've collected a case series and I want to do a genetic assay for it and probably create a registry. I'm also looking at biomarkers for osteoarthritis. There's quite a lot of exciting work going on in it. We're trying to do some really meaningful work in it, and we're in the process of doing that. I'm doing all of this as part of the SIMFA Research Foundation and the Tamare Healthcare, which is headed by my mother, Dr. Kanagi Uttaraj. Okay, so now, apart from collaborations, if you want to do research on your own, how do you go about it? I draw this from my own personal experience of how I learned it the hard way. There's a lot of, I still remember, I think the first review I wrote was returned to me probably 8 or 9 times. It was a proper systematic review. Never published it, but then I mean, every time it used to be returned back to me, I learned something new and I upped my game in terms of writing. So that's a huge learning process. So the modus operandi of how you go about it is you come up with a research idea. That's probably the most important thing. And then the research idea has to distill into a research question or a hypothesis. So you're either trying to answer the research question or you're trying to test the hypothesis. And then I think this is probably the crossover from the research idea to the question to the structuring. It's a place that we all falter in. Is you have to give it a formal structure. So you have to formal structure is not just introduction, methodology, results, conclusion, discussion. That's the writing structure. But the formal structure is the design of it. How are you going to do it? What are the resources you would need? Who are the people that you would need? What are the different areas of expertise you would need? The geographic locations, the other extraneous kit you would need, all of that. So you need to have, it's like a business plan. You need to have a very detailed plan down to the last screw of how you're going to build this project. Again, you have to formalize it. Formalizing most of the times is putting a pen down to paper and writing your ideas. If you do that, you will get to 50% of formalization. The next thing is to get your regulatory approvals. So in the UK, it's the Research Ethics Committee. In the States, it's the Institutional Board, the IB. In India, you have the local bodies, you have you have the ICMR, the Indian Council of Medical Research, you have the Clinical Registries of India, the Clinical Trials Registry of India, CTRI, and you have other university-affiliated regulatory bodies to whom you have to present your work and let them know what you're doing. So that regulatory oversight gives that amount of credibility and validity to the kind of research you're doing. I think the next most important thing is delegating your work. So you can't do the whole research by yourself. You have to assemble a team. You have to delegate your workflow and let people know as to who's doing what. And you have to make sure there is a reporting system and you convene every week or something and you check progress. Flag points, you have to establish flag points at every stage as to where you're getting to and what is expected and are you reaching there. And you have to make sure and audit and see if you're achieving targets at those points. So that's a brief talk about collaboration in research and how to go about it. So that's my name. If you're interested in collaborations, I'm more than interested to listen to what you have to say. You can write to me. It's nash.s.uttaraj@simfa.com. That's my mother's name, and that's her mobile number. And that's the name of the institution that I represent in India. Thank you very much. Thank you for listening.
Thank you so much, Dr. Nachappa.
Yeah, thank you.
For sharing these important and very important inputs. I would now request Dr. Preeti Gupta to please sum up the session. Dr. Preeti.
Yeah. Thank you, Dr. Nachappa.
Thank you.
There's always dilemma. What things are required for research? It's really very helpful for the medical students.
Please log out from one of the device, ma'am, or else it will start echoing.
Hello.
Switch off your mobile.
Yeah, I am using my mobile.
Preeti, just switch off one of your device, either mobile, either laptop.
Okay. Hello.
Yeah.
Hey.
Hear you now.
Thank you, Dr. Nachappa. It's
Pleasure
very
is mine.
useful to medical student as well as to us also, because
Yeah.
always a dilemma. We have to take help of which person that will help in our research. Thanks a lot for such nice talk.
No problem at all.
Hello,
Dr. Monica
Thank
Singh,
you.
do you want to comment? Dr. Monica Singh?
That was, yes, that was a very informative talk, Dr. Nash, if you would
Well,
allow
thank you, Dr.
me.
Monica. Thank you. Pleasure is mine.
Yes, and we have some phenomenal work in infertility going on in UK, and usually all the research in UK is spread all over the EU, and they collaborate so beautifully to present papers in international conferences that I've seen. And what is most impressive is the guidelines which they give. These guidelines are something which are guiding us in practice all over the world, whether it is in India, the Canadian guidelines, the European guidelines. So I feel that ways Europe has an edge over US. You know, the guidelines are clear. They're clear. It is very methodical. It is very clear. They are, brilliant, very evidence-based. So I feel that you can blindly follow it. It's been wonderful listening to you.
Thank you.
Thank you. Thank you for that. For the saving time, we will move fast, Doctor.
Okay. I'm going to sign off now. Thank you all. Thank you very much.
Thank you so much. Thank you for being here.
Yeah, thank you.
Thank you so much. Now for the second session, I hand over the session to Dr. Jyoti Banglawala.
Good evening, everyone. And thank you very much, Dr. Varsha Baste, Madam, for giving us opportunity for this wonderful webinar. There's a mixed bag of wonderful things. And today's lecture for Varsha Baste, Madam, our next speaker is Dr. Varsha Baste, Madam, for ectopic pregnancy management. And she took the International Exchange Committee to the new heights. The words fall short to for her achievements in the COVID times. She took so many things in the International Exchange Committee, and you can see today also the mixed bag of the topic, everyone's favorite topics like pregnancy management, acute management, and even the research things. So may I have the CVs of our chairpersons, Dr. Anjali Kanare, Madam Mudita Madam. Dr. Anjali Kanare, Madam, is the president of Bhopal Gynae Society and a very dear friend and very research-based practitioner in the medical college, and she is the professor and head of the department in the MGM Department of OB-GYN in the CMCI Bhopal, and president of Bhopal Obstetric Gynec Society. Our next chairperson is Dr. Mudita Jain Talesara. She is also professor OB-GYN and president secretary of Bhopal Society and past treasurer of Bhopal OB-GYN Society in 2019 and 20. Our third chairperson is Dr. Shashi Shail Bala Srivastava. She is practicing since 1984 in Riva, and she is having the Ganeshwari Nursing Home in Riva. So, Dr. Anjali, I request Dr. Anjali Kanare, Madam, to introduce Dr. Varsha Baste, Madam, in brief. Anjali?
Yeah, good evening, everyone. It's a proud pleasure for me to introduce none other than Dr. Varsha Baste. We all have heard a lot about her, and as Madam has already instructed, she just wants two-liner introduction for her. And I think the best part is her pitching in for Dr. Asha Bakshi when she's not there. So I guess she doesn't need much of introduction. It is her spirit that whatsoever comes, I'm here. So, Madam, the forum is open for you.
Absolutely.
And,
Thank you.
And I guess hands off to you for taking care of the webinar in Madam's absence. And I'm sure you will do wonderful work for the same. Thank you so much. Thank you for having me over on this platform.
Thank you, Madam. Thank you for nice introduction. And you said it, we have to keep going. The show must go on, irrespective of anything. So I will be sharing my slide just now. Can you all see this slide? Can you see my presentation?
Yes, ma'am.
Yes,
okay. I will be, now I won't show any video because we have to save the time. And Chaba has engulfed most of our time. Okay. So there's my talk, the ectopic pregnancy management. We all are doing this management, but this is just a brushing up of our knowledge. And I'm very happy to be here in the heart of India virtually. So the definition is an ectopic pregnancy is one in which the fertilized ovum becomes implanted in a site other than normal uterine cavity, and the consequences of abnormal implantation of the blastocyst. The incidence is rising nowadays worldwide. The mortality is decreasing only because we can diagnose this early. So we all know the sites of ectopic pregnancy, tubal, mostly up to 98% are tubal ectopic pregnancies, cornwall 2 to 2.5%, ovary, cervix, abdominal cavity less than 1%, and rare sites like rudimentary hall, LSK, scar, and other the abdominals and ectopics and all, we will be just, we will deal all with. Risk factors are PID. Six-fold increase in PID in incidence of ectopic pregnancy if the patient is having PID, or ICD use 3.3 to 5% increase risk, smoking 2.5% increase. ART pregnancy is most common nowadays, up to 5% increase in ectopic incidence. Tubal surgery is 5.8%, and then this prior ectopic. If the patient already has ectopic pregnancy, next pregnancy, tenfold increased risk of ectopic she may have. Age that more than 35 years, threefold increased risk. Non-white race, it is also racial, 1.5-fold increased risk. Endometriosis, definitely because of increased adhesions and the change structure. 1.5-fold increase of ectopic pregnancy incidence is there, and developmental errors, overdevelopment of ovum and external migration. ART, the first IVF you all know was a tubal pregnancy. So up to 8% of IVF tubal pregnancies are due to direct injection of embryo into fallopian tube, retrograde propulsion by uterine contraction, and pre-existing tubal damage. So these all prerequisite cause ectopic pregnancy, more incidence in IVF pregnancies. Now the site of tubal pregnancy. The tubal pregnancy is most common, and in that the femoral site of ectopy is around 17%. Ampulla is most common, is because the embryo gets stagnated or remains in the ampullary part, and it is little larger, accommodating part also. So it is least dangerous also, but the most common is site for ectopic pregnancy in tubal pregnancy is 55% is ampullary. Isthmus is most dangerous because highly vascular, 25% less common. Interstitial 3% rare, and tubal diverticula. I will not be showing I have removed the most of the videos, and I must thank Dr. Nitin Shah for contributing very nice specific videos which I asked him for unruptured ampullary pregnancy. Now the diagnosis of, I am not showing you the video, sorry for that, because it will become more lengthy. The diagnosis of ectopic pregnancy. Wide spectrum of presentation, it may be asymptomatic, or it may be the patient may come to you in shock. There is high index of suspicion. Think ectopic, but don't overthink ectopic. That is the motto. What are the clinical features? The clinical triad: pain, amenorrhea, and vaginal bleeding is there in 50% of patients. Pain is dull, cramping, colicky, or severe shoulder or back pain. Hemodynamic instability like shock, hypotension, tachycardia, and collapse. Or patient may come with syncopal attacks. What are the examination findings? Vitals are unstable or stable depending upon the condition of the patient. Per abdominally, there is distension, tenderness, dullness in the flanks. Per vaginally, there is cervical tenderness, adnexal mass we can feel, or adnexal tenderness you can see, and the patient may complain, and that are the signs which are diagnostic. What lab tests you ask the patient to undergo, and which are diagnostic? UPT is positive in 50% of cases. Because of the fluctuating beta ECG level, they may not rise to give, or the false positive, or the UPT test may not give 100% diagnosis, but beta ECG levels. The subnormal rise of less than 66% in 48 hours indicates non-viable pregnancy. But if the values of beta hCG are more than 2400 millimole, definitely you will see the sac in TVS 100% of the cases. And even if it is 1000 or 1500 in small stature patient, you can see the gestational sac. Serum progesterone more than 25 is normal in intrauterine pregnancy, but less than 5 nanogram is abnormal in pregnancy. Indicates abnormal pregnancy. Ultrasound, transabdominal sonography, if the beta hCG is more than 6005 milli international units, then you can see the ectopic in transabdominal sonography, or if the hCG around 2000, 1500 to 2000 milli international units, now you can detect it by transvaginal sonography also. The presence of intrauterine sac rules of ectopic. What are the uterine findings? It may be in empty uterus, you can see thickened endometrium or pseudogestational sacs in 8 to 29% of the patients. So ultrasound is diagnostic. Extrauterine findings, no findings are seen. Live dual pregnancy, adnexal ring sign, 38% you can see this ring of fire, also complex adnexal mass, free fluid in pouch of Douglas. And Doppler findings, road resistant high diastolic topoplastic flow pattern, and ring of fire is very, very diagnostic. Hypervascular flow around the ectopic, you can see, and empty uterus. These are diagnostic signs on sonography. Choledysynthesis, it is not used regularly, but due to beta hCG and TVS only are diagnostic. But we can confirm it. 18 to 20 gauge spinal needle is used to posterior fornix, and the flank blood is diagnostic, indicates hemoperitoneum around 90% and tubal rupture in 50% of the cases. Laparoscopy is the gold standard of unruptured ectopic diagnosis. So diagnostic may be missed in very small ectopic gestation. It is used as diagnostic and therapeutic tool too. Now, how will you manage the ectopic pregnancy? Expected management, medical management, surgical management, or surgically administered medical management. Surgical laparotomy or laparoscopy, milking of the tube, linear salpingectomy, salpingotomy, or salpingectomy. What is the expected treatment? The identification criteria is very, very important. You can give medical expectant treatment only if the diameter of ectopic pregnancy less than 4 centimeter, no signs of intrauterine pregnancy, no rupture seen on TVS, no sign of acute bleeding by TVS, falling level of serum hCG every 2 days intervals. And if there is a deviation from above criteria, then emergency treatment you have to give. What is the medical management? Methotrexate, obviously we are using different dosages, KCL, prostaglandins, RU486, and hypermolar glucose is given IV, IM, oral or local, laparoscopically or USG guided. So which are the candidates for medical management? hCG level less than 10,000 international unit, sac less than 4 centimeter, no cardiac activity, sac less than 3.5 centimeter with cardiac activity. Hemodynamically, the patient should be stable, accessible for follow-up and compliant patient, and there is no contraindication to methotrexate. Now, what is methotrexate? It is folic acid analog. It inhibits the dehydrofolate reductase and prevents synthesis of DNA. So single dose we can give, we know the ampoules of methotrexate 50 milligram are available. The success rate is about 96%, more than 96%. It is less expensive, better compliance, less side effects, less than 1%, comparable result to laparoscopic surgery. Methotrexate multiple dose regime 1 milligram per kg per day, followed by citrovorum factor 0.1 milligram per kg per day on alternate dates. Success rate is, I told you, more than 96%. The treatment is given till 15% decline in 2 consecutive hCG levels. What are the side effects of methotrexate? Leukopenia, thrombocytopenia, ulcerative stomatitis, diarrhea, alopecia, increased liver enzyme, because methotrexate gets metabolized in the liver, so the liver has to act more, and so the enzymes are increased. Now, how will you manage the hemodynamically unstable patient? You have to do the treatment of shock or take the patient. Surgical management is definitely needed. We have to admit the patient, IV live fluids, blood, plasma substitutes. Laparotomy or laparoscopy, decide as per your expertise. Clamping of blood vessels is life-saving. Auto-transfusion, we used to do lots of auto-transfusion when the blood banks were not readily available in good old days, and patients were saved. Examine the opposite ovary and tube. Don't forget that. Now the selection of laparotomy or laparoscopy. The patient should be hemodynamical stability is very important. The size and location of the mass is important. Your OT setup and surgeon expertise is very, very important. And if not availability of the laparoscopic surgeon on time is also very, very important if you are not a laparoscopic surgeon. So go for laparotomy. What can you do? You have to save the patient, do the total salpingectomy and take the decision. What are the advantages of the laparoscopy? Shorter hospital stay, faster recovery, lesser analgesia, less estimated blood loss, less adhesions, and tubal patency on ipsilateral side after consecutive laparoscopic surgery is 84%. So patient can have pregnancy, natural conception also, though the chances of ectopic increase in them, but we can advise them to go for natural conception if the mostly the second tube is, the ipsilateral tube is patent. So whether the selection of, whether the decision of salpingectomy or salpingotomy or salpingostomy, if it is ruptured or non-ruptured, you have to take the decision according to the ruptured or non-ruptured ectopic, desire for future fertility or badly diseased tube, you can go for directly for salpingectomy. So these criteria are very much important on whether you have to remove the tube or you have to just cut the tube and remove the product. So this criteria is very, very important because this rationale behind this scoring system rationale is that you have to see whether the patient will have recurrent ectopic pregnancy. The conservative surgery is indicated with a score of 1 to 4 and radical treatment is preferred if the score is 5 or more. So this is the slide of total salpingectomy, live ectopic. The videos I am not going to show, sorry for that. Chronic ectopic. Pregnancy doesn't resolve completely during expectant management and the patient lands up into chronic ectopic. The mass formation is there. So it gives pain, vaginal bleeding, amenorrhea and pelvic mass is seen on sonography and on PV examination also. Lower absent SCG level because the ectopic is, the pregnancy stops growing and so the SCG levels definitely reduce. But you can diagnose it by laparoscopy or by sonography. What is the treatment? Of course, removal of the affected tube, sometimes ovary also, because there are adhesion and inflammation. And chronic ectopic, there can be ovarian ectopic. So what are the risk factors with ovarian ectopic? Why it occurs? Because of IUCD users, pelvic inflammatory diseases, endometriosis, ART, they tend to give ectopic at the ovarian site. What is the classification for ovarian ectopic? Extrafollicular, interstitial, cortical, superficial, juxtafollicular, intrafollicular is less common. And this is the Spiegelberg's criteria, which tells us that fallopian tube on the affected side should be intact. Fetal sac, how will you diagnose the ovarian ectopic? Fetal sac must occupy position of ovary. Gestational sac must be connected to uterus by ovarian ligament. Ovarian tissue must be located in the sac wall. So the diagnosis is by sonography, wide echogenic ring on the ovary with yolk sac is seen. Differential diagnosis is corpus luteum cyst or hemorrhagic cyst. And you can do the laparoscopy and the diagnosis is done. So what is the treatment of this ovarian ectopic? You can go for a oophorectomy if there is advanced gestation. Try to conserve the ovary, but if needed, you have to control the hemorrhage. So uncontrolled hemorrhage, you have to remove the ovary sometimes, vase resection or methotrexate for persistent tissue. So the laparoscopy management of ectopic, sometimes there is ovarian torsion also. Scar ectopic has, the incidence has risen like anything because of increase in cesarean rate. The uterine rupture and hemorrhage is the presentation of the patient of scar ectopic. It is a dire emergency. The risk factor has previous uterine trauma, cesarean section, myomectomy, adenomyosis, and ART. The diagnosis is done by USG, Doppler, 3D USG, or MRI. So what is the treatment for this this car ectopic? Bilateral descending uterine artery ligation is indicated because it is bloody business. Local injection with KCl methotrexate is also advocated depending upon the ectopic size and the growth of and gestational sac. Laparoscopic resection with systemic methotrexate is also advocated. Uterine artery embolism is also adjuvant therapy, and hysterectomy sometimes patient has to undergo if there is a scar ectopic which is very much bleeding and non-controllable hemorrhage is there. So we have to this ectopic. Other unusual sites, intraligamentous. This the incidence is 1 in 300. Secondary implantation in the leaves of broad ligament. We can call it also abdominal, but mainly intraligamentous. Placenta may be adherent to uterus, bladder, and pelvic side wall. If removal is not possible, leave in situ and allow to resolve, and it will get corrected. So broad ligament ectopic pregnancy, then other sites are broad ligament ectopic pregnancy, then rudimentary rod ectopic pregnancy, or live rudimentary rod ectopic pregnancy, or bilateral ectopic pregnancy. Bilateral ectopic pregnancy is mainly this heterotropic conception is mainly because of rising trend of ART. So other unusual sites of multiple ectopic twins or like that are also reported. The treatment depends on location. Pregnancy after hysterectomy, most unusually seen after subcervical hysterectomy, that is the subtotal hysterectomy. We can see on the stump also. Corneal ectopic is very, very dangerous. The risk factor of previous ectopic or salpingectomy, uterine anomalies, apsilateral salpingectomy, IVF, ovulation induction, or STDs. These all cause the incidence is 1 to 2%, and mortality rate is also 2%. And how will you diagnose the corneal ectopic? Thin rim of myometrium around the sac is seen. Intrauterine pregnancy is very high in the fundus interstitial line, that is the echogenic line extending into the corneal region and averting into the gestational sac. So what is the treatment of corneal ectopic? Corneal resection by laparotomy or laparoscopy. Hysterectomy, sometimes you have to undergo, the patient has to undergo because it is a highly vascular area and bleeds a lot. Histoscopic resection under laparoscopic visualization is advocated. Histoscopic resection under USG guidance also is advocated depending upon the size of the ectopic. Methotrexate high failure rates because it's a high vascularity, it's washed away very fast, and late presentation and high HCG levels. Ruptured corneal ectopic, unruptured live corneal ectopic, unruptured corneal ectopic, and stump ectopic also is there post salpingectomy. Cervical pregnancy is very, very difficult to manage. The Rubin's criteria, cervical gland says that cervical gland must be present opposite the placental attachment. Placenta must be below the peritoneal reflection of anterior and posterior surfaces of the uterus. Fetal element must not be within uterine cavity, and hourglass is diagnostic. Uterus is diagnostic. Now, abdominal pregnancy, it may be primary or it may be secondary. The incidence is 1.54%, 7 to 8 times higher mortality than tubal ectopic because of abdominal pregnancy. The risk factor because why the abdominal pregnancy occur, ectopic pregnancy occur because of tubal damage, because of PID, endometriosis, ART, and multipidity. So this study for criteria says that the abdominal pregnancy, the tubes are normal, ovaries are normal, no uteroperitoneal fistula is seen, pregnancy exclusively related to peritoneal surface, that is abdominal ectopic pregnancy. How will you diagnose that? By sonography, no myometrium is seen between bladder and pregnancy, X-ray and MRI. What is the treatment of this abdominal pregnancy? Laparotomy naturally, ligation of placental blood supply and removal, abdominal packing needed for 48 hours, ligate the cord and leave the placenta behind if it is not removable. Don't juggle or tug of war with momentum adhesions, and just leave the placenta and it will get necrose. But if the pregnancy, sometimes the term pregnancy, abdominal pregnancy is rare but not unusual, and we know that they do occur. How they present? The baby is having growth retardation up to 20 to 40%. Babies have growth retardation if the pregnancy is full term, near term of abdominal pregnancy. Fetal pulmonary hypoplasia is seen, pressure deformities are seen, and facial and limb asymmetries also noted. Ectopic pregnancy with myomectomy, we will not discuss it, but it is very, very crucial to manage the patient with skilled hand. And so in summary, the key points are incidence of ectopic pregnancy is rising while maternal mortality is falling. That's a good thing. Early diagnosis is the key to less invasive treatment. Very good. We are diagnosing is early nowadays than previous good old days when patients were brought into shock because of sonography and all, and we are also alert gynecologists, obstetricians, and we can diagnose it very easily because we think ectopic first if a patient comes with amenorrhea and pain in abdomen. The choice today is laparoscopic treatment of unruptured ectopic pregnancy. That's the choice. Trend is towards conservative treatment. Careful monitoring and proper counseling of patients is mandatory. And ruptured ectopic should be unusual with compliant patients and appropriate medical care. Thank you. Thank you for your patient hearing.
Thank you, madam.
Dr. Varsha, madam, I'm not sure. Probably my secretary, Dr. Mudita, is not able to join in.
Okay, it's okay. Naz, anybody can summarize little bit.
Anjali, madam, you can sum up the topic, madam.
Yeah,
Anjali,
actually, madam has madam's presentation has been so lucid. I think she has done a wonderful job and she has presented every aspect of ectopic pregnancy so well. So words fall short to really express my thanks and for doing such a wonderful job, ma'am. Thank you so much. And yes, you have rightly pointed out ectopic pregnancy is again on a rise, and we are seeing all kind of pregnancies. Recently in my college, we had a patient. This was her 4th ectopic pregnancy. The previous one was a ruptured ectopic pregnancy. Then she came up with stump pregnancy. Then she came up with some other complication. And then now her presentation was with corneal pregnancy. So
oh my God.
Really life is becoming very tough for these kind of patients. With so many increasing technology and all other investigative modalities, still sometimes we have a lot of difficulties in managing these patients. Thank you so much, madam, for such a wonderful talk.
Thank you, Dr. Nanjali, for nicely summarized the talk. Thank you so much. I'm sorry I couldn't show you the videos because everybody is doing these such cases and we are falling short of time. Over to you, organizers.
Thank you, Varsha madam. Very lucid talk yours, and it is a very extempore and lucid talk in the last moment, and you proved you are the genius for everything. And now I hand over the mic to Dr. Dolly Mehra for the next session.
Thank you, Dr. Jyoti. Now for the third session on abruptio placentae, which is again a very important topic for acute complications during pregnancy. We have chairpersons, Dr. Amita Saxena, who is president of Gwalior OBGYN Society, and she has written books on Garbh Sanskar. Then we have Dr. Richa Dharwani, who is Joint Secretary, Jabalpur OBGYN Society 2019-2022, and she's Joint Secretary of IMA Jabalpur 2019 to 2020. Dr. Padma Shukla, she's Secretary of Riva OBGYN Society. I request our chairperson, Dr. Amita Saxena, to please introduce our speaker, Dr. Archana Base. She's going to speak on abruptio placentae.
Before that, let me congratulate and welcome Dr. Archana Basir, madam, who is a really prominent figure in FOXY and VP guide for me also during in the last year when I was a chairperson, and she is a wonderful leader and great orator, and done so much of work in imaging science committee. Thank you. Thank you, Dr. Archana Basir, madam, for having you here and gracing the occasion.
Dr. Archana, are you
Hello.
there?
Yes.
Archana, ma'am.
Yeah, I'm here, Dolly. I'm all here for you.
Good evening, ma'am. Good evening, ma'am.
Good evening. Good evening. Yes. Good evening, everyone. I'm Dr. Amita Saxena, President OBG Society, Jabalpur. Thanks, organizer, for making me the part of this important webinar. And I'm pleased to introduce Dr. Archana Baser, madam. Though she doesn't need any introduction, we have been growing up listening to her. Madam is a consultant obstetrician and gynecologist and director of Akash Hospital, Indore. And Madam was a Vice President 2020, Foxy Vice President. She's chairperson Foxy Imaging Science Committee from 15 to 17. And she was organizing secretary ISAR 2016. I welcome you, Madam, for delivering this important cause of perinatal and maternal mortality, abruptio pleasantly. Welcome you, Madam. Thank you, everyone. And especially thanks to Dr. Varsha Baste. She has a special place in my heart.
Thank you, ma'am.
She has been a wonderful chairperson during my tenure as vice president. And in spite of being COVID, where she could not take us abroad, because International Exchange Committee means she is supposed to take you around with her conferences, but she brought conferences from all over the world to us on webinar. So that was a great achievement, Varsha, and really you need, you did a wonderful job as a chairperson, and really I'm thankful for inviting me to such an important topic, that is acute pain in abdomen during pregnancy. And I'm really happy to see all my friends here from all MP around, and chairpersons, Dr. Richa, Dr. Amita, I can see Jyoti and Dolly, everybody is here. So it gives a great feeling. And then it is really something, what always inspires me is that gynecologists, even at 10 p.m., 9:30 p.m. in the night, they are ready to update themselves. People might be sleeping, doing something, some partying or something, but still these are all the gynecologists who I can see here are the top leaders in their city, and everywhere they are practicing, and but still they want to update their knowledge. I think gynecologists are commendable breed, and we really all must pat our back for all this. So I think we deserve applaud. And let me please allow me to share my screen.
These three beads of Indore are very famous, and they have stood up in Foxy, their own personality, their own stand-up and significance and presence felt in a Foxy world. Dr. Asha Bakshi, Dr. Archana Baser, and Dr. Kavita Bapad. All three Bs are very, very important personalities in Foxy.
Thank you so much, VB. And I think for our relationship between three of us is a great respect for each other. Yes. We respect each other so well. So that's the biggest bond we have. Absolutely. So let's get on to the subject. The topic which I am going to be talking is very close to my heart. And I think, as my chairperson has already said, that this is one of the problem which leads to maternal morbidity, at times mortality, and the perinatal morbidity and mortality. And we all have experience of seeing the patient with abruption from our PG days till the day we are practicing. So what I have chosen, the title is Too Early to Separate and Too Late to Diagnose, and Where Do We Stand in Managing the Abruption? As all of us know, abruptio placentae is an age-old entity which has been a part of our teaching since probably the beginning of obstetrics. It occurs in 0.4 to 1.5%, that is 1 to 2 per 100 pregnancies. Remember, it's a quite high incidence of all pregnancies, and incidence of abruption peaks at 24 to 26 weeks of gestation. So one has to be reminded when a woman presents with pain in abdomen, even in the second trimester, late second trimester, think about the abruptio placentae. I have brought few cases to highlight this point. Abruptio placentae and other obstetric abnormalities increase the risk of morbidity and mortality for women, fetus, and neonate. And with modern obstetrics, this problem should now become a historical one rather than a part and parcel of our daily teaching.
Hello.
And it is our duty as obstetrician to work towards this goal.
Hello.
What is important? Can you hear me?
Hello.
Yes, madam.
Yeah. How can we reach to this goal? One and very important thing is we should be alert. We should know that there can be an abruption. We have to do a diagnosis promptly. Ultrasonography, whenever you are doing ultrasonography, look at placenta. Most important thing in abruption is timely intervention, counseling of the couple, and the most important thing for the obstetrician is not to panic. Manifestation of abruption may include vaginal bleeding, uterine pain and tenderness, hemorrhagic shock, DIC, and diagnosis is clinical and sometimes by ultrasonography. If you define abruption, it is a premature separation of normally implanted placenta. Remember, normally implanted placenta from the uterus, usually after 20 weeks gestation, and it can be an obstetric emergency. And abruptio placentae may involve any degree of placental separation from a few millimeter to complete detachment. Its separation can be acute or it can be chronic, and separation results in bleeding into the deciduum basalis behind the placenta, that is retroplacentally. And if you look at the high risk, what are the high risk factors for abruptio placentae? If there is an older maternal age, hypertension, placental ischemia, that is manifestation which manifests as IUGR. If a woman with IUGR presents it with pain in abdomen, you should suspect that probably she might have abruption. Intraamniotic infection, that is chorioamnionitis, vasculitis, other vascular disorders, prior abruptio placentae, abdominal trauma, acquired maternal thrombotic disorders, tobacco use, and premature rupture of membranes, particularly in women with polyhydramnios, may be a thing which you should think of abruption. If you look at the symptoms and signs of abruption, the severity of abruption depends on degree of separation and blood loss. Acute abruption placentae may result in bright or dark red blood exiting through the cervix, that is external hemorrhage. But blood may also remain behind the placenta, that is concealed hemorrhage. As separation continues, the uterus may become painful, tender, and irritable to palpation. Hemorrhagic shock may occur, as may signs of DIC. Chronic abruptio placentae may cause continued or intermittent dark brown spotting. Abruptio placentae may cause no or minimal symptoms and sign. Complications of abruptio placentae, maternal blood loss that may result in hemodynamic instability with or without shock and are disseminated intravascular coagulation, fetal compromise, that is fetal distress and fetal death. Or if abruptio placentae is chronic, it can lead to growth restriction or oligohydramnios, and sometimes feto-maternal transfusion and alloimmunization due to RH sensitization. So to diagnose abruption, the very important thing is the clinical evaluation. Sometimes laboratory and ultrasonography findings. The diagnosis of abruptio placentae is suspected if any of the following occurs after the first trimester. If there is a vaginal bleeding, painful or painless, uterine pain or tenderness, fetal distress or death, hemorrhagic shock, DIC, tenderness or shock, disproportionate to degree of vaginal bleeding, you must suspect abruption. I think this is an age-old teaching, which is being taught to us by our professors also, that if the vaginal bleeding is less and the tenderness and shock is more, then think that internal bleeding or concealed hemorrhage is happening. Then how do you evaluate a case of abruption? Fetal heart monitoring, complete blood count, do a blood and RH typing, prothrombin time, PTT, serum fibrinogen, transabdominal or pelvic sonography, CLI or BETK test. If patient is Rh negative, and fetal heart rate monitoring, it may detect a non-reassuring pattern of fetal heart or maybe fetal death. Transabdominal ultrasonography, which is like my favorite subject, is ultrasonography, is helpful. However, findings with ultrasonography may be normal in abruptio placentae. Remember this as well. Sometimes, like, how do you treat abruption? Sometimes prompt delivery and aggressive supportive measures, that is in term pregnancy or of maternal or possible fetal instability, trial of hospitalization and modified activity. If the pregnancy is not near term and if the mother and fetus are stable, you may allow women to continue pregnancy. How do you deliver a woman with abruption? Prompt cesarean delivery is usually indicated if abruptio placentae plus any of the following is present, like maternal hemodynamic instability, you have to deliver. Non-reassuring fetal heart rate pattern, you have no choice, you have to deliver. And if it is term pregnancy more than 37 weeks and abruption, deliver, might as well save mother and baby both. Vaginal delivery, yes, it is possible to do a vaginal delivery with abruption when delivery is necessary, and vaginal delivery can be attempted if one of the following are present. You have diagnosed abruption, but mother is hemodynamically stable, the fetal heart rate pattern is reassuring, vaginal delivery is not contraindicated by vasa previa, labor can be carefully induced or augmented with oxytocin or by amniotomy, and preparation for PPH should be made. I've just brought a couple of cases. Stop me when you think that my time is over, so I can just cut down the number of cases, but I would highlight initial 3 cases and then 4th and 5th depending on the time. It was a 24 years primary, 25 weeks, 5 days, presented at 9 p.m. on Sunday with heavy bleeding and pain. I only did her previous 3 laparoscopic surgeries for torsion of ovaries when she was 22, 23. And she had I did emergency ultrasound. So that's another reason why obstetricians should learn to do ultrasound and should have ultrasound in their premises or wherever you are working, whether you are working even in other hospitals or somebody else's place, you should have a ultrasonologist available so that in this emergency you can pick up the problem. I did an ultrasound and found that there was a placental separation. There was no placenta previa. She has been with us for regular follow-up. She came from Dhar. And fetal heart maternal condition, we stabilized it. Steroids were given. I know it is too early, 25 weeks, baby may survive, may not survive. But when there is an abruption, 25 weeks, I gave steroids. And after a few days, when she settled down, we sent her home with instruction to report if there is a further bleeding. And we did a C-section at 35 weeks and she got a live baby, 2.4 kg. So the key points in this case, these are the pictures of her. Look at this, the placenta is getting collected. It means like you can see a big collection here and there is a hematoma. There are a couple of more pictures here. Look at a lot of retrochorionic hemorrhage happening here. This is again a big separation of the placenta here. Then there is a big separation of the placenta here. So, I mean, I was really frightened to death that I don't know whether I'm going to give the baby in hand, how the mother is going to cope. It's only 25 weeks. There's a big abruption. But since the mother condition was stable, baby was okay, we continued and her bleeding settled, though she came again with problems one more time before we delivered her. I'm just going to show those pictures as well. So the key points from this case is, this, as I said in the beginning, do not panic. If the maternal and the fetal condition are stable, do not rush to deliver just because it's an abruption. You can hospitalize, do a modified activity. Bleeding, if it is not threatening the life of the mother or fetus, just continue. Fetal heart rate was reassuring in this patient. The pregnancy was preterm, so we decided to continue. We know that she has torsion ovarian in the last laparotomy, almost necrotic ovary, and she had one ovary left and she had a very low AMH as well. So this approach ensures that mother and fetus can be closely monitored and if needed, She can be rapidly treated. Modified activity means refraining from any activities that increases intra-abdominal pressure for a long period of time. That is, women should stay off their feet most of the day, and women should be advised to refrain from sexual activity. Corticosteroid in preterm abruption should be considered to accelerate the fetal lung maturity if gestational age is less than 34 weeks. Pregnancy, if it is late preterm and you can wait for a couple of days, still consider the corticosteroid. And if the mother has not received previously corticosteroid, risk of delivery in late preterm period is quite high in the abruption. If bleeding resolves and maternal and fetal status remains stable, ambulation and usually hospital discharge are allowed, and if bleeding continues or if status deteriorates, prompt cesarean delivery may be indicated. And complications of abruptio placentae, example shock, DIC, are managed with aggressive replacement of blood and blood products. Then this is another case of covillier uterus. Covillier uterus was first described as the entity in 1911. We all have learned the covillier uterus. It's a hard, stony hard, purple color uterus. Covillier uterus is caused when hemorrhage from placentae, blood vessel seeps into the deciduum basilis, causing placental separation, followed by infiltration in the lateral portion of the uterus. Occasionally, the infiltration reaches the peritoneal cavity. This is a case which is a very, very unusual case. We reported this case as well because, as I said in definition, it is after 20 weeks when there is a bleeding, you call it abruption. But this young primary presented with bleeding at 18 weeks and mild pain in abdomen. She was vitally stable with regular fetal heart sounds, and on ultrasound, we found that there is a retroplacental clot of 7 by 6 centimeters. Admitted the placental patient with diagnosis of abruptio. By afternoon, the patient has worsened. Despite conservative management, and her hemoglobin dropped to 2 milligram. Uterus was tonically contracting with profuse bleeding per vaginum, and we had to deliver this in view of the deteriorating maternal condition. Look at the large hemorrhage, retroplacental clot on the ultrasound. And this we had to unfortunately do hysterotomy. We could not attempt the vaginal delivery. This was a classical picture of covillier uterus at 18 weeks. We delivered the fetus, which we knew is not going to survive, and unfortunately didn't survive because it was 18 weeks. Mother was stable after multiple blood and blood product transfusion, and she made a complete recovery. This is the fetus, and this is all blood clots. So there was a huge retroplacental clot, is shown in image here. Main message from this case is that always look at your patient. Abruption is a common condition which should be suspected in any case of antenatal bleeding and pain. Because we are talking today about the acute pain in abdomen during pregnancy, it's very important that even at 18 weeks, 20 weeks, think of abruption if there is a bleeding. Do not hesitate to do what is necessary. If the patient is deteriorating, take whatever steps that is required. We ended up having to do hysterotomy at 18 weeks to this patient, but we know that it was a life-saving and we needed to do it. So we did it. And there was another case, case 3. I think I'll stop after this. This was a case referred to us from periphery with complaints of decreased fetal movements. On admission, we confirmed an intrauterine fetal death. The patient had no excessive bleeding per vaginum. She did, however, have a tonic uterine contraction and deliver within an hour of admission. We found a large retroplacental clot, and a diagnosis of IUD due to abruption was made. This case was really disappointing because one patient was term and she had an IUD. Nobody likes obstetricians fear IUD, isn't it? The patient had no prior risk factor for abruption except a history of bleeding in second trimester. Had she been referred a little earlier, we could have saved the baby. Every history should be taken into consideration. A mother is the first doctor for the baby, and every complaint should be taken seriously. A little caution and extra precaution could have probably prevented a mishap in this case. And I think this, if you want to, if I have a time, just 2 minutes, I'll take this case number 4, which is again a very important case. 31 weeks primary, presented at 140/90 blood pressure with PIH. Ultrasound, a small abruption was diagnosed We admitted for observation, steroids were given, and I was planning to send her home, but after 48, even after 48 hours, her headache did not got relief. And I thought that probably I'm dealing with a Press syndrome because BP and a severe intractable headache. And I did a re-scan again, and what we found that her abruption seemed to have increased. Did an MRI, she had a Press syndrome. We stabilized her, did an emergency C-section and LSCS 1.2 kg. Mother and baby went 10 days. These were a couple of pictures I wanted to bring. Now, always on a scan, look at placenta. It can be very easily seen. It can be very easily learned to do a placental scan. Placenta tells a lot. You can diagnose placental abruption. You can diagnose placenta affreta syndrome if you know how to scan your placenta. Look at this, a big hemorrhage around the placenta in this case. And this is again, your placenta is here, and this is again large separation, about 6 by 2 by 3 centimeters. So abruption, hypertension, Press syndrome, we delivered her. So I would like to thank, I am now going to take another case, and this was our CTG with an abruption, where you can see there is a poor variability and almost a flat CTG. So thank you very much for kind attention and giving me opportunity to present my cases and discuss a very important topic. If there are any questions, I'm happy to take the questions.
Thank
Thank you,
so much,
Archana ma'am. Thank you, Archana ma'am, for very clear, crisp talk. And there is one question in chat box, that what treatment you gave to your first case, conservative management, in your conservative management.
Thank you very much for the question. I was expecting this question because whenever there is an abruption, always there is a rush to deliver. So when you talk about conservative management means what you have to do is, like any patient who comes to you with the pain, bleeding, you will give them an IV fluids, you give them an antibiotic, you give them rest, you give them hemostatic medication, some progesterone also, because we don't know, because she was a primigravida, she had no hypertension, why she had an abruption. So, like abruption, invariably our teaching is it is associated with hypertension. There is no abruption, nothing, there is no hypertension. So we just gave a IV fluids, antibiotic, progesterone support, hemostatic management, and corticosteroid in case if the abruption increases. In case if she gets worsened, we have good neonatal support. So even you can take a baby of 25-26 weeks and can give a chance of having a baby to them, though there's a lot of struggle in the NICU, but yes, you can do. So the conservative management, main stem of the conservative management was the progesterone and hemostatic medications.
Nice.
Dr. Richa, will you please sum up the session? Dr. Richa?
Yes, so good evening, everybody. I'm Dr. Richa Dhiravan from Jabalpur. First of all, thank you, Dr. Varsha Bhaste, madam, for having us here together on this night. And madam has spoken very well about all the abruption cases, the daily in life scenarios that we've been facing. Of course, the mainstay lies in conservation of pregnancy, as madam said, till you can pull on the viability and then manage as per the case differs. So thank you, everybody, and thank you, madam, for a wonderful day.
Everyone, thanks for patience listening and nice comments. So good to see you all. Bye for now. We meet at Jabalpur, Richa. Okay?
Sure, madam.
Yeah.
Thank you so much for a very lucid representation with the sonographic evidence. That was more interesting and really very nice presentation. Thank you so much.
Thanks, Varsha, for having me here.
Yeah. So for the fourth session on acute abdomen in pregnancy, we have Dr. Kavita Bapat as the speaker, and the chairpersons are Dr. Brijbala Tiwari, Dr. Jyoti Karande, and Dr. Manisha Maheshwari. Dr. Brijbala Tiwari, as we all know, is president of Indore OBGYN Association, and she's vice president of IMA Indore 2022. Dr. Jyoti Karande is secretary, Indore OBGYN Association, joint secretary, AICOG 22, and she's the Rangoli women for AICOG. Dr. Manisha Maheshwari, my own president of Ratlam Obgyn Association. So I hand over the session to Dr. Varsha Baste for a recorded session of Dr. Kavita Bapat on acute abdomen in pregnancy.
Just a minute, I'm sharing the screen. Dr. Kavita Bapat couldn't join because she was traveling and she has recorded her presentation, and so we are going to give you the audio visual.
In the meantime, Dr. Brijbala, please introduce Dr. Kavita Bapat. Dr. Brijbala, are you there?
Here I am here.
Yeah, Dr. Brijbala.
Can you hear me?
Yeah.
Yeah. Good evening, everyone. Thank you, Varsha Madam, for wonderful webinar and keeping us all together, and a very excellent academic evening. So for Kavita Bapat Madam, it's really, I am short of words. She is vibrant, visionary vice president, and it's my privilege to introduce her. She's organizing secretary AICOG 2022, and we all have seen the successful AICOG. She is director of Bapat Hospital, and she is the most beautiful with beauty with brain, lovely smile, and she's having great vision. So show must go on, as Dr. Varsha ma'am said. So it's good to hear her video presentation. Thank you very much.
Okay. I will share the presentation. Just a minute.
We'll be talking on acute abdomen in pregnancy, which has both diagnostic and treatment dilemmas in pregnancy. The gravid uterus makes diagnosis difficult, and an immature baby makes treatment decisions difficult. So let us hear from Dr. Kavita Bapat Madam, acute abdomen in pregnancy.
Thank you, Dr. Jyoti Karande.
Hi, today's topic is acute abdomen in pregnancy. It's a very important when we see the patients of acute abdomen, and these are type of patients are very troublesome. When to diagnose, how to diagnose, and how to proceed, and what has to be done. It's a really important point. As defined in the 27th edition of Sedgman's Medical Dictionary, that acute abdomen, any serious acute intra-abdominal condition attended by pain, tenderness, and muscular rigidity, for which emergency surgery must be considered. So acute abdomen in pregnancy, we should think many more things. Acute abdomen, it presents with the pregnancy, it has many possible causes. Clearly, the case of pregnant patient with acute abdomen is a clinical scenario that overlaps specialties. It's not only the obstetrician job, it's maybe surgeon's job, the gynecologist, and all the specialists of the maternal fetal medicines are dealing with the challenging situation. I'm sure that everybody practicing OBGYN, any patient who comes with acute abdomen during pregnancy, it's a really troublesome. There are so many causes that are incidental to the pregnancy. So we can distribute it into the gastrointestinal causes. It can be due to appendicitis. It can be pancreatitis. It is a peptic ulcer. It can be hepatitis. It can be bowel obstruction. It can be pancreatic pseudocyst. It may be a toxic megacolon. It's a mecal diverticulitis, herniation, bowel perforation, and gastroenteritis. So these are the main causes. But the causes incident to the pregnancy may be due to the genitourinary causes. First, I talked about the gastrointestinal. These are the genitourinary causes of acute abdomen. Number 1, ovarian cyst rupture. Number 2, adnexal torsion. Number 3, there can be a ureteral calculus. Patient with acute abdomen come in the morning, she is pregnant, and a sudden pain. We get worried, we get troubled. There are chances of ureteral calculus, and if there is a morning pain or something like that, then the rupture of renal pelvis. It appears to be a very unusual condition, but if it comes, it's really the acute abdomen, the havoc, and everything. Then the urethral obstruction is another point for the genitourinary causes of the acute abdomen. Now, these are the vascular causes of acute abdomen. It can be a superior mesenteric artery syndrome. It can be thrombosis or the infarction. It can be a ruptured visceral artery aneurysm. It's a very unusual conditions I'm talking about, but we should know when the patient of acute abdominal pregnancy comes to us. There can be a splenic artery aneurysm. So we have divided into three causes. One is the gastrointestinal, one is genitourinary, and the vascular. Now these are the other causes or the incidental during pregnancy. These are the respiratory causes of acute abdomen. Patient may be having pneumonia or a pulmonary embolism. Another, there can be intraperitoneal hemorrhage. The intraperitoneal hemorrhage because of the splenic rupture. There may be the history of trauma. We should take the proper history of the trauma for the acute abdominal pregnancy. Is very, very important. Acute intermittent porphyria, diabetic ketoacidosis, and sickle cell disease. These are also the incidental during the pregnancy. Now, these are the causes associated with pregnancy that we have. They were the incidental and they are associated. Can be with acute pyelonephritis, acute cystitis, acute cholecystitis, acute fatty liver of pregnancy, and rupture of the rectus abdominis. See the one that we come to the patient comes to the too much extended abdomen previous to C-section or something. It can be chances of the rupture rectus abdominis and torsion of the pregnant uterus. These are also important, and conditions resulting from pregnancy that causes acute abdomen in early pregnancy. As we all know, it's ectopic pregnancy, septic abortion with peritonitis, acute urinary retention due to the retroverted gravid uterus, all the prolapsed uterus and everything up to the 12 weeks or the 14 weeks. Patient comes to the acute abdomen because of the urinary retention and to the retrograde gravid uterus. Now, these are the associated conditions with the pregnancy, and they may be an acute abdominal pregnancy as a red degeneration of the myoma. I'm telling you, I myself has been suffered of the red degeneration of myoma, and this is not a good condition. And the torsion of the pedunculated myoma, then can be placental abruption, porphyria, and the HELP syndrome. We all about it. That's hemolysis, elevated liver function, and a low platelet syndrome, and a spontaneous rupture of the liver. Uterine rupture, all of us know, is the most dangerous and most troublesome, and a chorioamnitis. These also come with a pain. So why it's so important? Why we are worried about everything? So history is so much important. What is the time of the onset? What is the duration? What is the intensity? How the character of the pain and the associated symptoms, and establishing the gestational age early in the evaluation is early because it's like differential etiologies changes with different gestation ages. So we should be worried about if the pain is in the first trimester, pain in the second trimester, or the pain in the third trimester, we should be worried about. The diagnostic imaging, always the ultrasonography is the best because frequently you find out the gallbladder, the pancreas, the kidney, and we can evaluate easily. But there are the limitations when the later stage of gestation are there. It has got the graded compression with the diagnostic aid of appendicitis, and the size of graded uterus may limit the approach to pregnancy. So the sensitivity of MRI imaging for acute appendicitis was 80% compared 20% with sonography. So sonography is essential for the fetal evaluation. We should establish the gestational age, viability, congenital anomalies, amniotic fluid volume, fetal well-being. This information may become critical later in the management of gravid patient in abdomen and the decisions regarding the food, because so important in all these points. What will be the mode of the delivery? What will be the use of propolis? Steroid should be given, not to be given, when to deliver the baby. So acute abdomen is very, very important. And the radiography and computed tomography, they have got relationship, but ionizing radiation evaluation of patients pregnant, source of anxiety, and practicing clinicians, it's little different for the effect. And there's the procedures for this, and there can be abnormal for if you want to do the radiography for diagnosing the acute abdomen, there are chances of exposure in a different way. So the way the MRI has got the role, and etiology says the acute abdomen, we should do the MRI. Now, if we have diagnosed something, then what should be the timing of the surgery? What are the chances of this preterm labor? What are the spontaneous loss? What are the medication we can give? What is the emergency surgery? These all points should be consideration. Is anything like a laparoscopy we can do during pregnancy? Yes, we can do. In the past, pregnancy was considered contraindication for the laparoscopy, but multiple reports show laparoscopy for the diagnosis is also important, and it's not that troublesome. It can be done with guarded everything. Use of capnography during laparoscopy in the pregnant patients is recommended. Potential injuries to the gravid uterus should be worried. How much CO2 should be given? all these points are during this thing. And advantage is also there that can be diagnosis and surgery can be done of many patients. Now, why we are worried about acute abdomen? That's an obstetric concern. It's a preterm labor and a delivery, and the prophylactic effect of tocolysis remain unproven in this patient, and tocolysis should be administered with care. There are several causes of non-OBGYN appendix. I'm not going into detail, but telling you that we have to do it the way and we can treat it. Cholecystitis is one, appendicitis is one, pancreatitis is another important cause. So how to diagnose is how to differentiate what is the muscle guarding, what do we do, what are the things. And the intestinal obstruction, we take the right history, work up and a planning. Urothelitis is all the stones and everything is another important thing. When to put a stent. Rupture of the ovarian cyst is an our domain, and we should treat it in a nice manner, and we should be able to diagnose by peritoneal signs, tenderness, and a guarding. So rupture of ovarian cyst is another important. Another is an adnexal torsion that also we should be treated. Sometimes the dermoid and everything are there. So for the surgical therapy, adnexal, sometimes we have to operate on the adnexal muscle. Degenerative myoma is another bad thing, and it should be diagnosed rightly and when to given, what treatment should be given during the pregnancy are important. And these are the few points are very, very important. Placental abruption, we all know. Placental abruption, we all know. So these are the points, and we should be worried about all those points during the pain, during the pregnancy. So again, the uterus rupture is another big cause. We should do the right diagnosis. Sonography is useful, and treatment consists of emergency cesarean delivery, and all those points are very, very. These acute abdomen is one of the most important cause for one of the maternal mortality and morbidity also. So it workup and hepatic rupture is another. So I have given a big list. Even the ruptured ectopic is there. So these are the important causes. But the rare causes of the rupture of visceral aneurysm and any vessels may be there. So,
thank you so much. Thank you, Dr. Kavita Bapar. Thank you, Dr. Varsha Baste ma'am, for showing this video. And I now request Dr. Manisha Maheshwari to please sum up the session.
Thank you, Dr. Varsha Baste madam and team IAC committee to include me and for this very nice academic session. And we miss the presence of dynamic Dr. Kavita madam, but very nice video presentation by Dr. Kavita for this challenging situation of acute abdomen in pregnancy. I would like to sum up like this. There is need of detailed history taking from pregnant women. We have to keep in mind that pregnancy may alter the clinical presentation of this acute abdomen painful condition, and there are common acute abdomen during pregnancy, that is the obstetric causes, which includes ectopic pregnancy, ovarian torsion, abruptio placentae, and non-obstetric conditions include acute appendicitis, which is commonest one, acute cholecystitis, genitourinary causes like urinary calculus and all. So clinical examination is equally important, which the area of tenderness may help us to correlate the organ of origin of pain. And the diagnostic modalities like ultrasonography and MRI, and in few selected cases even CT abdomen can be done, mainly during second and third trimester of pregnancy, seeing when the benefit outweighs the risk of the fetal mal effects. And so the treatment depends of this acute abdominal pain condition depends upon the organ of pathology. Thank you.
Thank you so much, Dr. Manisha. Thank you, chairpersons. And now for the most awaited panel discussion on acute complications during pregnancy, I invite the moderators, the dynamic moderator, Dr. Varsha Baste, the vibrant Dr. Varsha Baste, and Dr. Shashi Bala Bhosle to please take over the session and conduct this panel discussion.
Yes, okay. I welcome all the panelists and all the dignitaries here present. So it's 10 o'clock, but we will finish off fast. And this panel is of esteemed chairperson. I really, the President and Obija Society of MP, Dr. P.K. Roy, Dr. Richa Sharma, many of them I do not know, but I know their names also very well. Richa Sharma, Mamta Jiwale, Uma Nigam, Yamini Manekar, Jagriti Nagar, Taruna Sharma, and Shanu Agarwal. So can you please briefly show the CV of each one? Just, I'm not going to read it, but you just show the CVs, because we have to start the panel. Dr. P.C. Roy, Dr. Richa Sharma, who is from Ujjain, Dr. Mamta Jiwane is from Harda, Dr. Uma Nigam is from Katni, and then so beautiful. And Yamini Manekar is from Harda. Then Dr. one more, Jagriti Kiran. She is the president of SOG, means Sagar. I just met her virtually. Very dynamic lady. Dr. Taruna Sharma looks so young. She is from Sanjay Multispeciality Hospital. So, and Dr. Shanu Agarwal, she is from Rohtak. So young, dynamic Foxians, all are the esteemed panelists. So let me start my panel discussion with by sharing the slide. Dr. Shashibala Bhosle may not join because she was traveling. Let us see if she can travel. I will take the proceedings further. So can you see the slides?
Yes, ma'am.
So acute complications in pregnancy, the panel discussion, let's move on. The esteemed panelists, I'll just again read it. P.K. Roy, Dr. Rita Sharma, Mamta Jiwane, Uma Nigam, Yamini Manekar, Jagriti Nagar, Taruna Sharma, Shanu Agarwal. So I welcome all of you, and I'm also thankful to all the chairpersons for being here. So what are the acute complications in pregnancy? Anybody can take the, Dr. Roy, you can take this question. What are the acute complications in pregnancy? Just now we have seen many of the talks going on, and we know all these things, but we just have to revise. Can you hear me, Dr. Roy? Or anybody?
Madam, it's a complication during first trimester, second and third trimester. They are usually divided, and we usually divide into all three trimesters. In first trimester, mostly ectopic pregnancy, incomplete abortion, missed abortion, return all. In second trimester, usually APH, abruptio, and third trimester also APH, abruptio, and fetal iodine and all that.
Very good. Okay, so the answer is, what are the acute complications? The acute complications are bleeding, miscarriage or fetal loss, ectopic pregnancy, amniotic fluid complication, placental complication, preeclampsia or eclampsia. Rightly said, Dr. Uma Nigam. We have to see first trimester, second trimester, and third trimester. So, what are the commonest causes of PV bleeding? What are the patient comes with an acute complication in pregnancy is PV bleeding, most common. What are the causes? Doctor, anybody can take it?
Yeah, ma'am. It's also depends upon the trimester wise. We when make out according to trimester wise. In first trimester, usually the most common cause is a miscarriage, a spontaneous abortion. Threatened abortion is the most common cause in first trimester, and in subchorionic hematoma also, and ectopic pregnancy also in first trimester. And in second and third trimester, the most common cause of this bleeding is the reveal type of hemorrhage, which is abruptio placentae, which already discussed previously, abruptio and placenta previa, both. And if suppose the case of a previous scar pregnancy, then uterine rupture may be also the cause. And in cases of preterm labor also, there is bleeding PV, and vasa previa also there is bleeding PV. Patient may present with the basic bleeding PV, and suppose the patient is having any cervical infection like erosion also, there is some bleeding PV. Patient may present with the bleeding PV. So we suspect all these things and treat accordingly.
Absolutely correct, Dr. Richa. Thank you. What are the risk of acute complication at every stage of pregnancy? The first trimester is most critical, second trimester and third trimester, our panelists are well versed with all the complications. So can we avoid these acute complications in pregnancy? How to avoid them, and what measures to take? Who is at the risk of such complications?
Ma'am, let me take this question. I can say that not all the complications can be avoided, but yes, many of them can be avoided. To avoid these complications, we have to take certain measures. And first is to identify those patients who are at risk of having such complications.
Yes.
We have already listened in earlier presentations that the patients who are at, say, who is having a history of previous multiple abortions or previous placenta, history of previous abruptions, previous IUDs, who is at less than 20 years of age or more than 40 years of age, who is having family history of IUDs or abruptions. Such are there is a long list of risk factors, though some patients having some medical disorders associated with them, like epilepsy or asthma. So we have to identify those risk factors, and then we have to take certain measures. In this case, I would like to suggest that we have to screen some patients who are likely to develop preeclampsia and FGR. And when we screen these patients, we can reduce preterm labor, abruptions, eclampsia, and preeclampsia. So one thing is at the 11 to 13 weeks, we can ask for a uterine artery Doppler PI values. And if it is high, we should not hesitate to start a low dose ecosprin, especially in high risk patients, even if they are not high risk. But there is a persistent notching in target scan also at 18 to 20 weeks. So these are the patients at 11 weeks. It's best to start the low dose aspirin if the PI value of uterine artery Doppler is high. There are certain biochemical markers also, but we cannot ask every patient to get those markers done, like MSA, maternal alpha serum proteins, MSAFP, and when we get very high levels of beta HCG levels and maternal serum alpha fetoproteins in quadruple markers, and the sonography is absolutely normal, amniocentesis is absolutely normal, there is no genetic disorder, we can think that these patients are at high risk of developing preeclampsia also. And there is a one simple test um, taking blood pressure, mean arterial pressure in mid trimester. Say a patient who is at high risk, and we take the BP, she is more than 35 years of age, she is obese, and she has a one history of, say, IUD or abruption, and we take the BP and it's just 130 by 80. It's not at high, but she is in mid trimester, and there should be a mid trimester fall, and there is no fall. So what we can do, ecosprin won't help much. Like, we have to sensitize the patient and the family members as well, that she should be under regular checkup to avoid such previous complications. And we should give right and high dose of calcium supplementations, magnesium, some antioxidants if possible. If she have if she could have arrived earlier, we can add ecosprin, and she should be in regular follow-up. At least we could sensitize the family.
Yes,
great.
Yeah, the Justice Score, we all know that app is very, very useful for such cases. So what are the signs of acute complications in pregnancy to get alert?
May I take?
Yes, please, doctor.
Yeah, ma'am, the signs of acute complications, again, we should think of trimester wise. Like in the first trimester, as we have discussed, the triad, the patient presents with the triad of amenorrhea, pain, and bleeding. We should think of the complication like ectopic pregnancy, because diagnosed early, we can really prevent the mishaps to happen, and we can manage them medically. And when we proceed further, in the first trimester itself, she can present with hyperemesis, and that has to be managed early. In the second trimester, third trimester, the patient presents with pain, we have to think of placental complications. And of course, headache, blurring of vision, epigastric pain, we have to think of blood pressure complications. So whenever the patient presents with pain, bleeding, headache, visual symptoms, we have to think of the complication that we have discussed and then manage accordingly.
Yes, good, very good, Yamini. So the answer is like vaginal bleeding, convulsion, hyperemesis, rightly Yamini said, severe headache with blood vision, fever, severe weakness, severe abdominal pain, fast and difficult breathing, reduced fetal movements, prom, and irritable uterus, severe uterine contractions. These are the signs which tell us the complication. So approximately 8% of all pregnancies land up into acute complications. Hyperemesis, gestational diabetes, placenta previa, preeclampsia, eclampsia, seizure, even acute depression, anxiety is also acute complication of the pregnancy, but we will all keep them in mind. So let us see the question and answer for each of the panelists. First one, you take it according to, because I cannot see all of you. Which of the following is the most common cause of first trimester vaginal bleeding? There are the multiple choice.
It's a spontaneous abortion, ma'am. 95% causes is because of abortion. Yeah.
Very good, very good. So the most common cause of first trimester?
Spontaneous abortion, yes.
Very good. Next question. What is the following is not a risk factor for ectopic pregnancy?
Previous ART is definitely previous ectopic pregnancy, previous STS, previous cesarean section is not.
It's not, yes, ma'am.
Because this is not a risk factor for ectopic pregnancy. All other are risk
It is a risk factor for star ectopic pregnancy.
Yeah,
Yes.
I know. Now it is common.
But yes, it's rare.
It is commoner now.
Nowadays it is very common. But
yeah, I know, Richa. Patient history is female comes with 2 days vaginal bleeding and cramping. LMP is 9 weeks ago. Urine test is positive. The additional testing includes all except
HCG is must, speculum, and PD examination is must. Yes, culdocentesis can be avoided. It is not required.
Try to do invasive investigation.
Yeah, exactly. Absolutely. You said rightly, you try not to do invasive. We can diagnose with our other modalities, the ectopic. The which of the following is not associated with increased incidence of abruptio placentae?
Okay, urinary hypertension, smoking, advanced age, dominant, advanced age.
Advanced age
Heroin
is not associated. Heroin.
The following is not associated with increasing increased incidence of abruptio placentae. So cocaine, hypertension, smoking, all these give increase occurrence of abruptio placentae. But heroin is not. That was little tricky. Means. Now the next question is patient history says that she is 36 years old, present with epigastric pain. Vitals are normal except for BP, which is 150/100. 2 Cs. So the next best action to immediate treatment is what? Hydralazine or
MGS of what? Magnesium sulfate. Yeah.
Slow push of 6 grams of magnesium sulfate, seizures, and control the neuroprotection also. Which of the following is expected abnormality in HELLP syndrome? Decreased HbB, elevated PT, decreased fibrinogen, elevated APTT, or above all?
decrease hemoglobin.
Absolutely. Decreased HbB is the cancer of the HELLP syndrome, abnormality of HELLP syndrome. Which of the following is the sign of magnesium sulfate toxicity? Atrial fibrillation, somnolence, hyperventilation, or diarrhea?
Somnolence.
Yes, exactly.
Somnolence. Drowsiness, somnolence.
So that is the sign of magnesium sulfate toxicity. A patient of 22 years old, 36 weeks pregnant, after treating her with magnesium with preeclampsia, she becomes somnolent with markedly decreased deep tendon reflex, decreased respiratory rate. So after managing an airway, what is the best next step to do?
Calcium gluconate.
The antidote for MGS.
Calcium gluconate. Do not take on dexamethasone or labetalol or atropine, but push her with calcium gluconate. Yes. Okay. So thank you all the esteemed panelists for such a wonderful and so well read and well studied. All the panelists. Thank you so much, Dr. Roy. I couldn't hear you. I think you left us. So okay. So
thank you,
over to you.
Thank you so much, madam.
Thank you, ma'am.
Thank you, madam. Thank you so much, madam, for giving this opportunity.
Yes.
Thank you so much, Dr. Varsha, ma'am.
Thank you.
It was a very new panel with just one word questions. So this was very nice and very quick.
Pre-PG time period.
Yeah. Pre-PG times, right. So now I request Dr. Pratibha Singh, ma'am, to please convey a vote of thanks.
Hello, yeah. Can you hear me?
Yes, ma'am.
Yeah, so good evening once again. So let me first thank Almighty God for making today's session a resounding successful. and academically advantageous. So firstly, I would like to thank all our viewers who were logged in for so long. Then my sincere gratitudes to our chief guest, Dr. Leela Joshi ma'am, for accepting our invitation and blessing us. So thank you so much, madam. And thanks to our guest of honor, Dr. Jyoti Bindal madam, Dr. Rosa Olier, Dr. Vidya Pancholi madam, for their gracious presence. And it was a wonderful scientific extravaganza, and I'm dead sure that you all must have enjoyed the enlightening talk by Dr. Nash, Dr. Archana madam, Dr. Kavita Bapat video presentation, and Dr. Varsha Baste madam. And our panelists were wonderful: Dr. P.K. Roy, Dr. Richa Sharma, Dr. Mamta, Dr. Uma, Dr. Yamini, Dr. Jagrati, Dr. Taruna, and Dr. Shanu. So thank you so much for sharing your knowledge with us. And I also take this opportunity to thank our chairpersons, Dr. Monica, Dr. Preeti Gupta, Dr. Neha, Dr. Anjali, Dr. Mudita Jain, Dr. Shalbala Srivastava, Dr. Amita Saxena, Dr. Richa, Dr. Padma Shukla, Dr. Brajbala Tiwari, Dr. Jyoti, and Dr. Manisha. Thank you so much for wonderful interaction and making each and every session so interactive and informative. And I'm also immensely thankful to our Master of Ceremonies, Dr. Dolly Mehra and Dr. Jyoti Banglawala, and my co-moderator, Dr. Shashibala Bhosle Madam, for such smooth coordination. So it was wonderful. Thank you so much. And finally, no good event can happen overnight. It requires a lot of planning. So congratulations to Dr. Varsha Baste Madam for such wonderful execution of and successfully completing this central zone webinar. So congratulations, madam. And we are also very fortunate to that we have been backed up by the dedicated team of Shield Connect. So for their logistic support. So thank you so much who were there. And once again, a big thanks to all our viewers, delegates, faculties, and the guests. And we value you and your valuable time, which you have spared for this webinar. So once again, thanks a lot for your valuable time here. Now, our next webinar will be in September. So till then, stay tuned. Goodbye and good night. Thank you so much.
Just a minute. Can everybody be on a video? Because I want to take a photograph. Whoever is present, please, Vidya Pancholi, Brajbala, Dr. Monica, if they are there, please switch on the cameras. I want to take a photograph. If you are there, please. And I'm really thankful to all of you to be here and gracing this occasion and the great academic partnership with Dr. Mr. Who really worked very hard, flawless, and without any hitch, it was continued. Thank you so much. And I am really thankful to you. In September, we are having 3 webinars. First September, 7th September is about research for medical students abroad and Indian. Then 1st September, there is all about amniotic fluid. Then 15th September, all about placenta. So it will be enriched by esteemed speakers. Just wait and watch and just log in.
Thank you very much.
Thank you so much. Shabba khair, dhanyawad.
Thank you.
Thank you. Good night. Good